Good evening. The Arlington County Board is now in our work session on COVID-19. And it has been another busy day. We will go shortly to the manager. Much happening. I believe our positivity rate is down to 4%. But we still, of course, face the threat. We're working on vaccines, and our entire staff leadership is focused there in addition to the budget. But I will send it over to the manager as we start an hour-long plus work session on COVID-19 vaccines and response.
Thank you, Mr. Chair, members of the board. With me this afternoon are Dr. Varghese, Dr. Miller. We also have Dr. Helfer. By the way, we do employ people who aren't doctors, just to put everybody at ease. What I wanted to do was get right to it and turn it over to Ruben, who had the pleasure of calling me at 7 o'clock this morning to give me the news on the Johnson & Johnson vaccine. And we have some news for people who have signed up for appointments. We have appointments all the way scheduled through Sunday, so he can talk about that, and also a little bit of a discussion about what it is we know from the CDC. So over to you, Dr. Varghese.
Thank you, Mr. Manager. Thank you, Mr. Chair. So it's been an eventful less than 24 hours, less than 12 hours. Imagine starting a day thinking that you have J&J vaccine scheduled all the way through Sunday, and suddenly the whole state of the nation is asked to pause and not issue it. And the reason why we had so much J&J vaccine this week was because the state had allocated us more resources in Northern Virginia to try to get as quickly to phase 2 as possible. So just to reassure people that we, first of all, surprisingly had a misdirection of vaccine earlier this week from the state. They thought that we hadn't gotten our order for second doses, and so we got an extra shipment of Moderna. And so we were blessed to have that accident actually help us. And so the first thing we did this morning was, when we recognized this problem, we made the decision that we could actually substitute the mRNA vaccine, Moderna in this case, for at least the doses today at Lubber Run. And so that's why we were able to hold that clinic. And we actually notified people through the system and said that they would be able to get vaccine. It just wouldn't be the Johnson & Johnson vaccine. And then staff worked diligently to see, between that happy accident and anything that may have been left over, little drips and drabs, we have been able to put together enough to be able to assure everyone who had signed up for the J&J vaccine at Lubber Run, they were our first doses, that they will actually be able to get an mRNA vaccine through Sunday, which is when our clinics were open through. We will have absolutely no margin left to start the week, which is why when we do get our allocation, we will not be starting our clinics till probably Wednesday of next week. But we wanted to make sure that we were able to honor all of the commitments if we had vaccine available to that. So to make it clear, everyone who signed up for the J&J vaccine at Lubber Run through Sunday has a mRNA vaccine waiting for them if they choose to keep their appointment. So we are encouraging everyone to do that. So let's start with the good news, even in this time, and let's hope that tomorrow we'll learn better news. Just so that the public is aware, the CDC's outside expert panel, the Advisory Committee on Immunization Practices, is supposed to meet tomorrow to review the situation. And to put this in context, it's 6 cases of a very rare thrombosis out of 6.8 million people who have been vaccinated in the U.S. with the Johnson & Johnson vaccine. Not saying it's not a significant thing to look into, but that's 6 cases out of 6.8 million people. And roughly in the US, as a general rule, if I remember the statistics, it's anywhere from 2 to 14 cases per 1 million individuals. So when this type of clot is seen in other circumstances. So need to keep that in perspective, and that's probably as much as I would probably speculate. Let's let the experts take a look and see what the situation is, and I'll be happy to take questions about that. Given that, I thought that I would go through some of the slide presentation, and so I don't know who's running the slideshow. I believe it's Ryan Hudson, and if it's not Kendra, if you could do the slideshow, that would be great. So if we could go to the next slide. So this is becoming a familiar graphic for everyone. This is showing the number of cases in Arlington that have been reported to us through a number of means. And we've been hovering in the mid to upper 200s, which is better than we were in January. And it would be better if we were lower still, back to where we were in June and July of last year. But I will take this much level of activity if we need to. So just a reminder, we have COVID in our presence. There's a reason why we're pursuing vaccination as much as possible in this nation, because the more we can get people vaccinated, the risk for transmission and the development of variants will go down. Next slide. Don't know if Dr. Miller wants to take this and discuss COVID testing at this point.
Sure. Good afternoon. Thank you, Dr. Varghese, and good afternoon, Mr. Chair, board members, and Mr. County Manager. As has been previously reported, Arlington County continues to provide about 20% of the total COVID testing capacity within the county. So to date, for the entirety of the COVID emergency, we've seen about 220,000 total PCR tests conducted across all sources. The county is responsible through its efforts in providing about 45,000 of those tests to date. So again, about 20%. As Mr. Chair, as you mentioned, the test positivity rate, the rolling rate of average tests that are positive over the past 7 days is about 4%. We have seen the number of tests increase slightly over the past few weeks. We're now seeing about 800 to 900 total tests across the county. Again, about 20% of those coming from our sources. On the slide that we have displayed, which is now becoming very familiar, we've got a listing of the locations across the county where we are offering county testing services. So we've added one starting this week in the courthouse area, an additional kiosk to provide low barrier, no cost, no referral COVID testing through the Curative Kiosk, which is the same company that our partners in Alexandria and Washington, D.C. and others throughout the country are using. As a reminder of the additional locations, we've got the Arlington Mill Community Center, which continues to operate as another low barrier, no cost, no insurance testing site. Tucker Field at Barcroft, and then our mobile testing site. You may remember we transitioned the drive-through testing site at North Quincy to be the mobile site that you see there in the bottom picture. They are at 601 South Carlin Springs, but starting next week on Monday, April 19th, they will move to Marymount University for a period of 2 weeks. You can visit the COVID website to learn specific details about each of the testing locations, including time. You can make an appointment, although walk-ups are welcome. And then we also have updated information about a variety of at-home or other private provider test options. So we've seen the market for at-home test options begin to really take off. We're following that closely, watching what the FDA authorizes through its emergency use authorization for over-the-counter, for example. And we've included some information about how you can obtain those at-home test kits and also other private testing services that are available.
Thank you, Dr. Miller.
All right. And resuming, let's talk about the status of vaccine distribution through Arlington Public Health and where the health district is in general. So people I think are familiar with this graphic, although now it's reduced to 2 colors. Vaccines being scheduled for the following groups: Phase 1A, those who are healthcare workers and long-term care residents; Phase 1B, residents who are 65 and older; residents 16 to 64 with medical conditions and disabilities, and frontline essential workers, and phase 1C, other essential workers. Through last week, we had invited everyone that we had on our rolls through the state system and our own local system. But as we've said, there are times when people will register since that time. And so since last week, we've had an additional 1,200 people either pre-register or their status has changed in the system. In addition to the general public, which would be moving into phase 2, at the moment we have 28,000 people who would qualify in phase 2, and we're on the cusp of moving into that. And just as a reminder, it should open up next week to start inviting people, but everyone is eligible to sign up to express their interest, and we are encouraging everyone who lives in Arlington to pre-register by visiting vaccinate.virginia.gov, or you can call 877-VAXIN-VA, which is 877-829-4682. So you can register in the system, and then as we pull down the names to invite people as vaccine becomes available, we can continue the process that we've been very good at being effective and efficient to get people in. Next slide. As an update of what the division has been doing in the vaccines, you'll see that we've administered over 50,000 first doses. We've administered over 25,000 second doses, which I think is phenomenal for where we were given just 4 months ago. Obviously, we'd like to have more vaccine to be able to provide even more shots. This is my opportunity to also talk about the state did allocate us more resources in Northern Virginia to try to get us to the phase 2 area. One of the things that I need to remind people of, that level of vaccine availability is going to go down. As an example, 2 weeks ago, we had 11,000, close to 12,000 first doses to be able to give. This week, just over 9,000. Next week, as part of the Commonwealth shifting back to a per capita allocation, we are only going to be receiving 6,000 first doses. And so obviously, we're sad that we can't get more, but that is the Commonwealth trying to make sure that everyone's roughly at the same place with phase 2. And then as they see the uptake, if we see lower uptake in some of the traditional areas, unfortunately, if the rural areas don't have the uptake, which we'd like to see, they will start shifting the vaccine to the more populous centers. So we will have vaccine, just not as much as we've enjoyed for the last several weeks. And if we can go to the next slide. So this is, I think, an important graphic, and it's new to all of you. It's just showing you how many Arlington residents have been vaccinated and their status through April 10th, and that's 16 and older. So let me orient you to the slide a little bit. In the gray area at the very bottom, you'll see a number 197,592. That is the state estimate for the number of Arlington residents 16 and older. So that's the eligible population that, you know, we're looking at for this vaccine campaign. And of that, we've had 39,974, or 20.2% in the dark blue, are now fully vaccinated. Another 39,160 individuals in Arlington, or 19.8%, have received at least one dose. And combining that, we're at 40% of our population, of the eligible population, having had at least a dose of vaccine. And I think that's a very good place. And of course, we would like to do better. Obviously, we need vaccine to do that, but this is for all of the people receiving vaccine in Virginia that are Arlington residents within Virginia. This is likely an undercount because the vaccinations of our people in DC and Maryland will not be part of this. We are working to get some of that information, but I am sure that this number will go up should we be able to get the DC and Maryland information. So the positive thing is we're moving in the right direction, and as we keep moving, I'm hoping by the end of May we'll at least be closer to the 60% initial vaccine target of getting 60% of our eligible population vaccinated. I would be overjoyed if we got to at least 75%, but we're moving first to the state target of 60%. Next slide. So I know you've all been interested in some of the race ethnicity data. We've tried to make it as simple as possible, and so I'll have to explain this a little bit. Let me first of all tell you, this is the Virginia data, okay? And then the next slide will be the Arlington data. So this is a data set with that number of roughly 76 to 79,000 people who have been vaccinated in Virginia. If you look at the specific numbers, that previous graphic was 79,000. If you look at the individual cells here, it's about 76,000. We're trying to get the state to explain why they've lost 3,000 people from one data set to the other, but it is what it is. Let me explain some of the information here. The purple, or 11.7%, is the Hispanic or Latino category. The NH abbreviation is for non-Hispanic, and so some of these data sets don't show up because it's close to zero or under 0.2%. The most important thing to notice is how many in the state database have missing or unknown race ethnicity data. It's 47.8% of the data is missing. And then if we go on to the next slide, which is why we look at this with a little bit closer perspective for the 50,000 people, we know the information. This is the data for the Arlington County Public Health Division, race ethnicity data. The missing and unknown category here is 7%, which is a significant difference. We'd love to be able to get that even further down, but we can't force people to actually tell us that information. And so that's the race ethnicity data. I think the important point is, and I know it's been raised before, as we look at it and try to figure out a way to present it to you, it looks like all of the groups are getting more vaccine. Is it ideal? We'd love to have everyone at 100%, but it is improving, and I think some of the efforts to enfranchise people have been working. We know that the neighborhood health and the Arlington Free Clinic efforts have vaccinated probably close to 2,000 individuals. Obviously, it would be better to even have more, and very grateful to the CDC efforts to try to get more people enrolled, and which is why the Vaccinate Virginia activity is a very important thing, because those are the lists that we're going to pull for the general public as well. So I think we're going into the home stretch. This is a slide of the vaccine distribution locations in Arlington. Reminder, all vaccines are administered by appointment only at these sites, because we have to make sure that these events do not become super spreader events. We've pointed out in the past, Arlington Public Health has 4 sites currently available to use as vaccine centers. We started out at Sequoia. We have, in the last several weeks, used Lover Run, Walter Reed, and the Crystal Drive Amazon headquarters, running 3 simultaneously. In the next several weeks, we'll probably be down to 2 most of the time, given the volume of vaccine. Going to the federal pharmacy program, currently CVS, Harris Teeter, and Safeway are the ones receiving vaccine through those programs. And looking for vaccine there, you can go to vaccinefinder.org. And then our 2 equity partners, Arlington Free Clinic and Neighborhood Health, are listed there. And we can go to the next slide. Finally, vaccination in the community. Reminders, calls made for vaccine appointments, some of the statistics. We've had over 3,000 people call to schedule appointments for vaccines, a total of 7,000 phone calls, follow-ups, et cetera. 7999 supports nearly 700 incoming calls per day. We've been doing vaccinations for people in correctional facilities or homeless shelters who are also part of Phase 1B. We have started with field missions to reach vulnerable populations like transient residents and nursing home folks. And finally, the homebound vaccinations for those who are truly homebound, as the DHS staff have been able to determine their status. We've identified about 30 individuals, and the plan is to start vaccinating those individuals in their homes. The original plan was to consider offering them J&J vaccine. We are not planning on doing that, so we do have to rejigger some of that, and that is one of the things we're committed to doing. So that is, I believe, the end of the slide deck, and happy to take questions.
Thank you, Dr. Varghese. I'll just start with one I'm pretty sure is the case. You mentioned the appointments at Lubber Run. Do I understand correctly that all of the 3 sites through Sunday, we're going to be able to keep the appointments that we have scheduled? Is that right?
So we're keeping all of the appointments. You're absolutely right. It's just that it was only Lubber Run that was really seeing first doses. So and so instead of the Johnson & Johnson vaccine, we're now going to have some combination of Moderna or Pfizer to complete that instead of the J&J. Sometimes we've done first doses or second doses at some of the other sites so that there's no confusion among vaccines and so on, so that we can try to keep it as clean as possible so that it reduces the element of mistakes and so on. So if we try to have 3 at one site, that can become sometimes confusing, and we don't want to have errors in vaccinations.
Great. Well, as you and so the community, so great that we're not canceling any appointments that have already been set. So that's one big picture takeaway. I hope everyone will get it home, and we'll go around with additional questions, starting with Ms. Garvey.
Yes, thank you. I also wanted to say, I mean, well done that, we didn't have to cancel any. Obviously there was some luck in there, but just really well done. Considering that they're, going back to the, who knows when we'll get to the one-shot one, could you remind us when you get your first shot, how much that gives you some immunity, I believe, and I can't remember how much. So I just was wondering, because it might be of interest to people, that if we can at least get 1 dose in people, I think even that makes a difference.
Yeah, absolutely a good question, Ms. Garvey. Roughly, it's between 60 and 70% for the first dose of the mRNA vaccine, depending on who you look. So I think at a minimum, we can say it's greater than 51%. We'll take whatever we can get, and that means we're going to get closer to better immunity for our community. So that's why we're presenting the information as the partially vaccinated, because it really does give better protection than having no immunity at all. Exactly.
Thank you for that. And then one more question. I don't think we know yet how much, once you've had either fully vaccinated or partially, that prevents you from actually spreading it. Is that, I think it's looking more and more that vaccination keeps you from spreading as well as from getting it, but I think maybe it's not sure yet.
Right. So another good observation. We are getting better information that it seems like it does reduce the risk for spreading. What we don't know is how long that is going to be the case, but that should not surprise anyone. We're learning this information, and we're doing the natural experiment as we go forward. It was the only way we can do it. So the one thing I do know is they already know that instead of 3 months of protection from serious illness and death, they've seen that it goes to at least 6 months because they've had that length of data. So they're trying to follow it from the studies that they originally started with, and these natural experiments will, in a sense, as all of us get vaccinated, then they're going to look to see who has gets infections and at what point. If it's a few initially, it may be more that it was ineffective for those few people. But if suddenly 8 months later, I'm making this up, people sort of 50% of the population is vaccinated now gets infection, we'll go, okay, maybe it only goes that long. So unfortunately, there's only one way for us to find out, and that's why the CDC and FDA systems to report this and look at it just like they discovered these rare events. There is active surveillance to try to look at this information on a population level. So the system is working as it was supposed to be, although obviously if we had if we had little Purdue thermometers, which is my wish in life that we all had Purdue thermometers for coronavirus, we would know exactly when each of you were infected, but maybe that's a little too big brotherish. So
that maybe a little bit. Thank you very much. Very helpful. I will yield the floor. Thank you.
Thank you, Ms. Garvey. Mr. Karantonis.
Thank you, Mr. Chair. Dr. Varghese, I assume that what we always say, the first vaccine available to you is the best vaccine you can get. So that means that if the CDC tomorrow or the day after tomorrow reapproves after careful consideration the J&J vaccine, we will resume with administering this vaccine, right?
That is a good question, and that is my understanding.
Okay. Second question, quick. So we are moving towards, and maybe Dr. Miller as well, we are moving towards phase 2, very, very soon, hopefully the soonest. So what is exactly so we will still be requiring or asking everybody to register with vaccinate.virginia.gov, correct?
Correct.
And what will be the prioritization modus there? First come, first served, first registered, first served, or are we going to have the opportunity to find ways to be more targeted, especially with our vulnerable communities?
So, great question. So we first still, according to the governor's plan, if there are people who identify as phase 1 individuals, they would be swept up as we've been doing and still putting them through. And then given that we have been actually doing through CDC, the registrations of those individuals, it will be first come, first served within that registration scheme. But that is, once again, how that will be done. That is why it's very important to get more and more people registered who are interested. There are other opportunities out there, the federal pharmacy programs that people will go to, but that is the current way, is to absolutely get people registered. That's why the CDC, I think, is a very important function to get people registered. And as more and more sites become available, there will be just more choices for people to go and get vaccine. I don't know if Dr. Miller wanted to add anything to that.
Yeah, I just want to reemphasize what Dr. Varghese said there, that the pre-registration system and putting your information into vaccinate.virginia.gov allows us to identify individuals who may be in a priority category or who have underlying medical conditions or health conditions. As he said, we, for the past few weeks, for example, while we have been in phase 1C, as we have received updated information from the state pre-registration system, we've gone back and been able to offer those individuals the opportunity to schedule. So, for instance, we had some folks who were 65 and older who had just now gone into the system and registered. That allowed us to be able to specifically send them an invitation to register when we had appointments these last few weeks, and thereby ensuring that they essentially weren't missed or didn't have to wait until the next round of general invitations are opening. So yeah, this one benefit is that it does allow us to target and ensure that we're not missing folks within the system.
Thank you. I yield, Mr. Chair.
Thank you, Dr. Miller and Dr. Varghese. Mr. Dorsey.
Thank you, Mr. Chair, and much better conversation despite the Johnson & Johnson news, much better conversation than we've been having. And I'm actually taking the luxury of looking forward and assuming that we'll have success with an authorization for the emergency use for children as young as 12, which seems like it's looming on the horizon. So the first question is, do you have any, not to make a prediction, but any sense of timing of when that might be available, if it follows the the approval process and timeline of the initial approval? And then two, if you could speak a little bit as to what it's going to take logistically to manage the flow of vaccinating people who I presume will need to have a parent or guardian present. Logistically, will that impact our operations and change the way we think about distributing vaccine to that age group?
Great questions. So we do know that Moderna and Pfizer are both working on trials for children 12 to 15. And so when they are ready to submit, when they believe they've cross the T's and dot the I's, they will submit for the FDA for EUA consideration. And I have no reason to believe that they're going to have difficulty with that, because they've done a good job to this point with the previous studies. And I think with the attention that the whole world is having on this, they know it's important to get that right. Assuming all of those go well, I'm hoping we'll see it by early summer. And that's, maybe more my hope than anything else. And then obviously we are working to incorporate them into the clinics as needed. If we think that it's important to do it in a separate venue, we'll look at that. But hopefully if we get the adult population dealt with by May and June, then it's really then going to be the kids. Our first focus, and this is a great opportunity to remind parents, children can be 16 and older, can be entered into the Vaccinate Virginia system, and parents are bringing it. So I'll use this opportunity to say, this is the opportunity. They don't now just have to be children with underlying medical conditions. They are part of this population. So parents who are listening, or if you have friends with children, encourage them to get registered in the Vaccinate Virginia system. This is a way that we can ensure that Arlingtonians are going to get vaccinated, because that's the other thing. If we don't have those lists, we'll do our part. It's federal dollars that we're also using to help pay for some of this. We'll open it up to other individuals, but my first priority is to get Arlington residents vaccinated. So the more we have in the Vaccinate Virginia system, we can pull their names down to enroll them and enfranchise them in this system.
Thank you.
Thank you, Mr. Dorsey. And Ms. Crystal.
Thanks. I'd actually love to pick up where Mr. Dorsey left off. One of the things, just as a sort of step back reflection, that's been challenging, and I think that by and large the county staff has just extraordinarily risen to the occasion, but it's sort of an opportunity to remind ourselves that, like, actually usually government is not in the business of giving vaccinations, and so this is more or less an unprecedented effort. But I think of that particularly with children. Obviously, most children, including many of our low-income families, even if adults don't have a medical home, often their children do, because that's services that we provide. And so they're in the practice of getting vaccinations through their pediatrician or a school clinic. Is there any reason to hope that with so many medical professionals now being vaccinated and more adults being vaccinated, that we might start to see some of this run through those traditional channels when it gets to children? Or do we think that because the scale of the operation will likely still be vaccinating young people and children in the same way we vaccinated the adult population?
Great question, Ms. Crystal, and let me try to provide a larger context of how we're approaching things here in Arlington, maybe compared to some other communities. Because we've had the resources, we've centralized more things to make it as effective and efficient as possible. Other communities don't have the resources we've had, and so they've relied on partners and hoping that they will follow the rules in certain ways. We've no harm, no foul, just going to assume everything's working perfectly, all the places that's happening. We actually are one of the largest providers of vaccine for children. So that's another thing that people aren't aware of, because so in that sense, we're actually a lot of physicians, doesn't mean all pediatricians, but a lot of physicians do send the kids to us to get vaccinated, because our hours are much more flexible in some ways. We've even done it during this past pandemic. We had to now schedule it in a way versus doing these open calls where anyone and everyone could be there to prevent the transmission. So the Community Health Services Bureau and the School Health Bureau work together to provide those vaccines for children, especially before school entry. So we will continue to do that. However, if the amount of vaccine is sufficient, then it's easier to then have more of it go out into the private provider community, because the problem is, especially for the disenfranchised populations, to have to go find the vaccine versus one place where it's easier to get it through. Once again, my goal is to ensure that we get to that herd immunity and make it as convenient as possible. But if the vaccine supply gets more plentiful, then we in the state will be able to just let more and more people have access to that. But while it's not so convenient, and especially with the adult population, we've been saying, all right, we can actually ensure both the vaccine safety. We've got the generators in place. Like if there's an electrical issue, we've got the backup systems in place. A lot of practices don't have that. And given how precious this vaccine is, we, knock on wood, want to prevent any adverse excursions of temperature. Fancy way of saying, if it goes out of temperature range, we've lost vaccine, and we don't want to do that. And we've got backup generators and the special refrigerators and freezers. It's one of the things that I've been very proud that the county has made sure that we have those assets and resources. It's why some practices have preferentially over my 15 years shifted, and it's the same thing for most of the nation. They may shift it to the local health departments. We become almost the vaccine provider experts.
Thank you. That's a great, that's so interesting that actually vaccinating children may be more in our traditional bailiwick as this operation continues. I don't know, Ms. Garvey had a question on the children under 16. I wanted to ask 2 others, but I can yield to while this conversation's ongoing.
Ms. Garvey.
Yeah, just real quickly, because I have to say I'm reminded, I first met Dr. Verghese when I was on the school board, and he had, I think, just come to Arlington. You headed up the H1N1 vaccine effort through our schools.
Yes.
And we had the Surgeon General. I mean, we wanted like an award recognition for vaccinating in our schools, getting the children vaccinated. Do you see us possibly going to that kind of an effort? When you were just answering Ms. Crystal, you sort of didn't mention like going in, by September, hopefully kids are going to be back in school. Do you see that possibly happening?
I'm not sure yet. It really depends on the order that this is being done in. If it's 12 and older, it may be just easier given the timing to have people brought to the centers, because in that way, we still have those economies of scale to make it also as friendly and pay attention to customer experience, because that is the other piece. And I'm not talking traditional customer experience. We're talking about, is it medically as safe as possible versus if you have 20 sites. I'm not saying people can't do well, but that means we have the possibility of more mistakes happening. It's just that possibility. So we're trying to balance the best of both worlds to be very effective and very efficient. And so that's why we often have our clinics at the Sequoia building most of the year, just because we know we can do things in a particular way. So that's the medical piece that we're trying to assure. What happened in H1N1, because there was such limited supply and it was children that were more at risk, we took an approach that the state really didn't want us to. But to assure equity, what we did was we said we would go grade by grade. We didn't do it school by school. We literally did a grade by grade. That was the difference. So we saved enough vaccine and then said it's all kindergartners first and second throughout the county. We were not going to say it's, this school on one side and this, because how do you explain to a parent how you chose a school? So, but that was also a different virus that affected children more than it did adults. So it made sense at that time with limited vaccine. If that was what was happening here, we would think about the elementary school model first. But of course, we also have to negotiate with the schools because they're trying to get education going on. So that's been one of the other pieces where it's not always as simple right now. But if there's plentiful vaccine, my first goal would be probably keeping a certain number of sites. Will it be the same places? That could be different. Maybe we will be back in some of the high schools or middle schools because maybe they won't be in session. But we know that the school system has been supportive of that. Just we haven't planned on that quite yet because I think we're a little bit away from that. And I don't think it'll be as difficult to get the schools to help with that at that point. And I'm not implying that they were difficult to work with on this at all. Just they have another mission as well. So.
Exactly. No, thank you. Thank you for that reminder and that explanation. I do tell people that you've been doing this a long time, and it's really good to know how you think it through. I will yield back to Ms. Crystal, but I also do want to say the customer experience. I know you're worried about medical safety. Great job. But what I have been consistently hearing from people, just really very pleased with their experience when they come and get vaccinated. So thank you very much for the excellent job you're doing. Thank you.
Thank you, Ms. Card. Ms. Crystal.
Yeah, I appreciate that. And it actually tees me up really well for a question I want to ask. And this is a really challenging one. I can't imagine there's a simple answer to it, but I think what I'm asking for candidly is advice for us when we're out in the community talking to people. Part of the reason I think it's been so important for Arlington to run these clinics, as you were describing, is for all of the medical reasons, the chain of custody for the vaccine, for example. And then it's also, call it the customer service experience, call it accurate communication of expectations. One of the most important things, and I know that you and Dr. Miller and your teams have been training all of our volunteers to be very clear on this about how we ask people to identify themselves, because we know that that can really easily turn into rumors or perceptions that somebody has to be a citizen or has to show legal documentation that could then be used against them, right? Because they have mixed status or aren't documented. As we are starting to see more, the kind of proliferation of more vaccine sites, I know we saw one in the community this weekend or past 2 weekends in partnership with an Alexandria-based pharmacy. On the one hand, I know we welcome anyone else getting into the business of getting as many shots in arms as possible. On the other hand, we've seen very real consequences. I actually just was seeing somebody on social media the other day in a way that broke my heart, mistaking this for an Arlington-based clinic. And when someone was asked for ID there, who was undocumented, that can create a ripple effect of fear. They also were told at the end of the day they had, quote, run out of doses, which was that model, which is very definitively not been our model, that if we schedule you and you show up for a dose, there is no running out. And so there is a real tension here precipitated by this event, but I suspect we're going to start seeing more of it as more pharmacies participate in the vaccine program or doctor's offices or whatever else. Do you have any advice for us on how we communicate that tension about both welcoming more vaccinators and then also trying to keep clarity of message on some of these things that are so important and may make the difference about whether somebody feels comfortable signing up for a shot or not, when we can't always control the message? Again, call it customer service experience, volunteer training, or whatever else. Any insights you can shed on that hard question?
Sure, Ms. Crystal, I have been thinking about it for a while. What a lot of people forget, and I'm going to be a little philosophical here. When people hear public health, they have that traditional sense of it's for poor people, okay? That's not what public health is. It's about populations. And this is one of the few times that I've tried to remind people, as a physician trained in public health, we're looking at trying to improve the health of all populations. It's different than maximizing one individual. That's the majority of medical care. Very important thing to do, not questioning that at all. But as a matter of public policy, as I understand it, we're about maximizing populations, not specific individuals. And this is one of the few times, if we're trying to get to herd immunity, if that's the important goal in many ways for us, and that is herd immunity for all populations to a certain level, okay, then that's a function that has to be, in my mind, well coordinated and well planned out. If the goal is to get as many people vaccinated, so you will hopefully not see me for several more years when this pandemic is over, you'll be like, we're okay not seeing you, Dr. Varghese. Take it personally. I'd love to not have to do this on a routine basis because it means we are not having a pandemic. So that's one of the things I would try to remind people. There's a goal here that's beyond each individual. So the reason why, if we can try to balance that effective and efficient place where people can trust the system to approach and we can achieve economies of scale, the goal here is different than normal vaccination practice, normal medical practice. And so that is something that you all aren't normally talking about, but it's no different than in a lot of the other public policy decisions you're making. It's for populations that you're trying to improve this for. It's just typically, I'm not doing a doctor-patient relationship with one person anymore. My patient population, and in many ways, your patient population, is the population of Arlington. And how do we help people realize we're trying to get to as many people vaccinated so that if it's roughly the same percentage, the exposure risk to other people will go down because so many more people are vaccinated. It's a lot to have to communicate, but I think if you're patient, that would be what I would try to remind people. The goal here is a little bit different than enfranchising one doctor or one pharmacy. We've got a different goal. We want as many Arlingtonians vaccinated as quickly as possible and as efficiently and effectively. And you've seen what we've been able to do even with like the race ethnicity data. We get better outcomes. Doesn't mean we're perfect, but if that helps guide public policy, that's one of the things that we do. And I'm not going to say we can rest on our laurels. We can always improve, but obviously we first have to have vaccine, and then however people's creative to get people into the system. And I'm starting to see the numbers, even myself, going, okay, they're going in the right direction, and more people are being enfranchised. Could it be better? I'm not going to disagree. Yes, it would love to be better, but that's what I would consider, offer to you to think about, and I'm happy to hear comments or questions.
I really appreciate that, and I won't speak at great length, but I will see that difference of sort of the individual health maximization and the population health is such an important frame. And I think too about, you know, the sort of conversations I'm having in the community, which is I don't think any of us would begrudge a neighbor for taking advantage of whatever might be popping up in their neighborhood, right? We all have an obligation to our families and loved ones and ourselves to maximize our individual health. And I also think that maybe when we think about the cascading effects, especially of vulnerable populations who have very good reason to be mistrustful of the system, maybe the best message we can give is, you know, to work through these channels, right? To participate in a neighborhood health event by working with the safety net or the faith community you already know, or to pre-register. Again, my goodness, please pre-register. That's all we can ask for, so that the county can find you and schedule an official vaccination appointment with you. You know, that is also good advice, right? So thinking about both the individual and the system level. I really appreciate it. I'll yield. The only other thing I wanted to say is that graph on the percentage of eligible Arlingtonians who have gotten at least one shot, and two, so helpful, exactly what I was asking for when we last met. I think that is sort of the eye on the prize so many want us to have. I share your itchiness that data is incomplete, and we know that it's an undercount because we're not getting folks registered or folks vaccinated in DC and Maryland, but just having that, you know, as we can all watch our progress together, I think is going to be invaluable, and I really appreciate it.
Thank you, Ms. Crystal and Dr. Varghese, for that conversation. We'll go to Mr. Caratonis. We have a couple more questions. We also have a presentation based on Saturday and the complete vaccination committee that we want to get to briefly in addition, with pop-ups, et cetera. So I'll go to Mr. Caratonis. I might try and squeeze a question in myself, and then Mr. Dorsey.
Thank you, Mr. Chair. Since we are going to be talking about pop-ups later, I think one of the major logical lines from the conversation with Ms. Crystal and Dr. Varghese, the one that I want to follow on, is that yes, there are various pathways towards the herd immunity goal, right? And we know that neither vulnerability nor, you know, the vaccine or the registration is normally distributed in the population. So we still have to do everything we can, you know, to be present where the biggest need is first. So first exposed, first vaccinated if we can. But this will be talking about that a little bit later. I have one other question that really keeps me up at night, and I'm very honest with you. We are seeing what's happening around the world. I'm concerned about variants and the prevalence of variants in our population, and how we are measuring or monitoring this, and what this means for our efforts going forward.
It's a great question. So we're part of a larger system in Virginia, and fortunately at hospitals like Virginia Hospital Center, when they identify cases, they actually have the ability to do some testing to start the process for variant detection. Could the US system be much better? Obviously, if we had many more resources to build that sort of public health infrastructure. That isn't the case, but we get an idea of roughly are variants present or not, and which types, and then they go to the state lab, and if they eventually they will detect certain ones, and they will no longer need CDC guidance to get further testing, but anything that's brand new or odd, they'll send to CDC. Variants are present in the region. The real point is the vaccines right now seem to be effective against variants. Are they as effective as without them? No, but that's going to be one of the pressures we're always under. Human beings exposed to the virus and then getting the virus in them create the opportunity for variants to be created. We are all potential living laboratories, which is why the sooner we can get vaccinated as a globe, notice I just said globe,
Yes.
which is why we do need to focus on the US. Well, first let's focus on Arlington, then the US, but we've got to get so many more people vaccinated so that the opportunity for variant development significantly goes down. Because variants happen with flu. That's one of the things that people don't realize. Every flu season, what we start off the flu season with and what we end with a flu season, depending on the year, Mother Nature has that ability to have the virus evolve within our own bodies. So this is not a new phenomenon. It's just that we don't usually pay attention to flu or go, oh, flu's not a big deal. So your concern about this, Mr. Carantonis, is a very important one. It's why we're all, I think, in agreement. The more we can get people vaccinated, but that is also why, and that's why it's important to do all the other layers of protection. Because if we can prevent ourselves from being exposed, because even though to Ms. Garvey's point originally, it's like how effective it is and maybe not spreading, we don't know when the spread can occur. And so why take the risk? Let's try to take as many of the precautions still possible. I want people to enjoy life, get back together again, but let's do it sensibly so that the risk of transmission continues to be low and the risk for variant production also is low. That would be a health goal of mine for people to consider why vaccination and doing these things as we get together. I hope that gives you some information about what you asked.
Thank you.
Yes, it does. Thank you.
I'll just, I want to kind of highlight and see if Dr. Varghese or Dr. Miller, if you have thoughts. Keeping all the appointments this week is fantastic. We're looking at some difficult math over the next few weeks. 28,000 people are in phase 2 already, pre-registered in Arlington. And we're looking at a decrease for a number of reasons. One is Johnson & Johnson frozen, but even before that, there's a lot of Johnson & Johnson that had to be didn't work. 15 million doses out of the Baltimore facility approximately. So, I mean, those in phase 2, those who have been waiting and have not identified as in 1B or 1C, this is a difficult couple weeks. I don't know if you have, I mean, that 6,000 is for us next week. There's also the pharmacies and neighborhood health. So it's not only what we will be doing, but after so much progress, we now have new facts and we have difficult math for 2 or 3 weeks. Is that a summary that's accurate? What do we say when a 60-year-old emails and said, I've been waiting for 2 months? We really have to say, we're going to work in order, but we have a little slowdown in supply. Is that what we're looking at the next couple weeks or so?
I will start and then I will let Dr. Miller adjust things. So I think it's a both and in many ways. There is more supply in some ways. It's just the supply we got was to catch us up, okay? There's no ifs, ands, or buts about it. So they shifted things to Northern Virginia where there was a larger population. Whether we agree or not, there's a per capita allocation model, and until that changes, again, we're going to get less vaccine. Having said that, I think they've already recognized that the uptake, because some other parts of the state have moved into phase 2, they're starting to peter out. So I think what's going to happen is we're going to see allocations of what they didn't use up being shifted more quickly. So I think there's hope, one, from that perspective. Also, all the federal pharmacy programs that are available, that's why sites like Vaccine Finder are useful. If you're willing to, going to what Ms. Crystal was talking about, there's both population, what you all are doing with public policy, and I am, and then there's the individual policies that people follow. If people can find vaccine and they're part of that group, go to a pharmacy where you can get the vaccine. You don't have to wait for one of our clinics. I think there's some people go, I must wait for the Arlington clinic. If you're eligible and have the means to do it, is it fair? That's a different question. We're creating the opportunities, trying to compensate for things here. And so if the belief is, let's use all of the systems that are available to Arlingtonians. And so I think we focus on, we are going to get more vaccine. I'm hoping it's going to be sooner rather than later, because I think we're going to see, unfortunately, the rural areas are probably not going to have the uptake that they should have from a health perspective, and they'll start reallocating that vaccine to us probably a bit faster than they did the first time. Dr. Miller?
No, I think Dr. Varghese, explained it fairly well. One of the things that I do want to point out is, we've got to remember that in total, Operation Warp Speed had a number of different vaccines that the federal government had sponsored and were in development, in addition to the vaccines not within the Operation Warp Speed system. And as soon as the CDC can work through some of the discussion, and the ACIP, the Advisory Council on Immunization Practices, can review the evidence, come to a determination on Johnson & Johnson. And there are still other vaccines out there in the system that continue to work on development. I think all of those point to the fact that supply hopefully should be increasing soon. And we've seen sort of what the public health system is capable of these last few weeks, when we were able to do several thousand individuals a day, almost 3,000 individuals a day, given the supply.
Great, that's really helpful, in that we may see a challenge next week, but we will all be advocating at different levels with our county manager, Dr. Varghese, and we will as well, and things broadly will continue up the uptick, but we are also facing real challenges in the next week or two. After that, we have significant hope, of course, and we're still working as hard as we can. Mr. Dorsey.
Thank you, Mr. Chair. I've got a couple questions, but I think they're quick. First, I'm encouraged to hear that maybe there's hope again for a demand-based allocation model from the state. Given their central system, there's no reason why it's not really actually easy to do. So I'm glad that maybe is possible. Beyond that, do we have a sense from, have we been tracking the number of people who decline the invitation once they've been offered? And do we have any sense of why they decline, whether it's because they've already gotten it or they've changed their mind, or are we just tracking the overall number of people who decline the invitation?
It's a great question. I'm not sure we quite define it as decline. Here are a couple of ways what we learn. We make the invitations, and then obviously those who accept it by scheduling it, we know about. Some of the people we've invited from the state system, we check against the list to see if they've actually accepted vaccine. That is more as we've gone forward. We've had people who were hesitant who got invited early on, who waited till they saw their neighbors in the natural experiments saying, okay, I'm going to use it. We saw Miss Garvey, she did well. We saw Mr. Dorsey at some point, or Dr. Varghese, they did fine. They then may decide to do it. So that's why we haven't been so draconian in saying you have 2 weeks to make a decision and then you're out. Because if the goal is herd immunity, so that's like another one of those competing priorities thing. It's like, how do you gently help people all along, because they're at different places in this vaccine acceptance process. So it's a long way of saying we don't have a great way of saying how many people didn't. I'm sure we could figure it out, but the juice may not be worth the squeeze, since we don't know if they've gone into Maryland, for example, to get it. But as we put the data points, that's why that horizontal thermometer, in a sense, is hopefully going to show us we're getting closer and closer to, I'd love to see us at 190,000 people vaccinated. I'll probably cry uncle if we get to only 7,000 not vaccinated. I'm not quite sure we're going to get that good. So,
and so, Dr. Varghese, is it safe to assume then that the 28,000 registrants that we have for phase 2 likely includes some number of people who have either A, found another route to vaccine, or ultimately will decide not to accept the appointment?
Some percentage will fall into all of those categories. Some weeks we've had amazing uptake with we may only put up 3,000 or 6,000 invitations and suddenly everything's filled. And sometimes we may put up to 14,000 and we may only get 6,000. And there's no way of quite understanding why that's happening. In some ways I'd love to know, but we just don't have that information.
Thank you. Well, hopefully that gives our chair, Mr. DeFerranti, some comfort that it may not be as dire as you're seeing with the math. And then on the last point, and check me if this is just really my ego wanting to know if we're better than our numbers indicate, but might there be a way of doing a survey of our community, through some reasonable means to find out if people have been vaccinated outside of Virginia, just so that we could get some statistically reasonable estimate of how many Arlingtonians have been vaccinated. And I think I'm not asking for ego. I'm really seeing this as a critical cog in getting people comfortable engaging in community to the extent that they desire, is having some reasonable assurance that people around them are vaccinated.
Well, it's interesting. I think you used the term interesting cog. And so that's the transition to, it's amazing what the Council of Governments and the Health Officials Committee are planning on doing. And our manager may be able to comment more, but they are asking each of the COG localities to contribute whatever data they have about who's been vaccinated from outside. Because as you know, part of our CDC plan was not just residents, but essential workers who could be from your community or elsewhere. So we know we have vaccinated people from Montgomery County, DC, the district, or Prince George's County. So trying to put those parameters so they can say, by what date do you know this, and so on. So it's like with like. So we'll get there, but it's already reassuring. It's like that they want to move in that direction. So that's why I was fairly confident to say and speculate with Ms. Crystal. I think we're going to get a little bit more of that thermometer filled in, which is what we're really trying to do. So it's not ego, but it's a 3-letter word named COG. So.
Thank you, Dr. Varghese and Mr. Dorsey. I didn't mean to paint it too dire. I just also wanted to, it's complicated. Demand-based vaccines is what we've been arguing for. A little bit of it is acknowledging the challenge on Johnson & Johnson that's in this moment. But that doesn't mean we're not making progress. And certainly, while I like other Northern Virginia jurisdictions, I always want us to be first. And yet that's their challenge is that everybody's working hard on it. So we are doing a lot. And thank you to Dr. Varghese and Dr. Miller. I do know that, send it to you, Ms. Crystal. I know that you have at least part of a report, many of us and many volunteers out this weekend trying to get the word out so people will pre-register and making sure that all different parts of our community are hearing about the importance of getting the vaccine. Ms. Crystal.
Sure. So we have just a couple of slides. I know we're a little past our planned time, so I won't belabor anything. But this was our day of action this past week. And I think you all have come to know the Complete Vaccination Committee well from previous presentations. We have a slide deck. I should probably confirm that it did make its way to our clerk. And if it didn't, I'm happy to pull it up myself. So Madam Clerk, do you have this? All right. Seeing none, I'm going to go ahead and request. Nope.
We could also share it with.
Let's see. Share content. All right. Okay. Hopefully you all are looking at a presentation committee now. Great. Yep. Okay. So those who watch the county board recess meetings have heard me present. Hopefully you have in some way been touched by the CVC in your own life, but as a brief reminder, this is a group of citizen leaders, resident leaders, with the goal of educating the public, building confidence, and above all, encouraging vaccination. We have at this point 154 partners, including everyone from faith communities to, I know recently, our service employees union chapter just joined. These are folks who are able to liaise back with their communities, trusted nonprofits, service groups, commissions, businesses in our communities, participate in a partner training. We've now done 5 of them, and help disseminate information to those that they work with throughout the community. And excitingly, the CVC is truly underway in every sense of the word in Arlington, hosting over 40 different pop-ups, which I think at this point nearly every one of my colleagues has participated in, to do a total now of 850 on-site pre-registrations. Again, we really are driving people to that pre-registration process for all of the reasons we've talked about during this work session. It helps us so much when you pre-register. It helps us know whether you might actually have been in a 1B category and we should prioritize you, even if as we move into the general population. It helps us collect that data on your race and ethnicity, which we then use to ascertain whether the vaccination rollout is happening in an equitable way. Above all, it just lets us find you and schedule you for an appointment that you can predict and rely on. So that those pre-registrations are really the gold standard, especially considering that all of these pop-ups have been in places where we're trying to reach some of the most vulnerable members of our community. 6,000 Vax VA flyers distributed with information about how people can register themselves. And while we're at it, over 1,500 COVID health kits, masks, hand sanitizer, and all of that important PPE. This Saturday was our day of action, and this is especially a chance to just say an enthusiastic thank you to the dozens and dozens of Arlingtonians who participated, CVC members, county board members, and residents who came out and engaged in a multitude of activities to spread the word. Thanks to your work, we distributed more than 4,000 door hangers in apartments, going door to door to get that message out. Multilingual Vax VA median signs placed. I know nearly every Arlingtonian has probably seen one of these in their own neighborhood. Outreach to more than 250 different retail stores to place signs and educate their customer base, and more of those support signs distributed. These are just a couple of snapshots of what this day of action looked like for those involved, and it really does come back to this effort especially when we're talking about that goal of reaching our full population with the vaccine, and above all, I'm going to stop sharing here, above all, reaching those who might not otherwise get our messaging. So thank you, colleagues, for those of you who were involved. Thank you to all of the volunteers who participated, and a huge thank you to our communications team, especially under the leadership of Dr. Brian Helfer, including Jerry Solomon and Tanya Boujbrel and Jennifer K. Smith. Jeremy was out there capturing video. Others I'm surely forgetting. You all are just extraordinary and have made this possible. And the last thing I just want to highlight briefly is the role of our Arlington Public Schools and the Complete Vaccination Committee has been invaluable, especially Dulce Carrillo, who does community engagement and has been a tireless partner of the CVC, Dr. Barbara Cannonen, who's been involved from the leadership level, but true integration and helping get this information to parents and helping elevate suggestions. I know Mr. DeFranti and I were in a leadership meeting recently with the superintendent who highlighted that he was hearing from parents of English learners and refugee students that misinformation was circulating in places like TikTok, the need for short Spanish language sound bites. This was something that the community was able to follow up on, and had some volunteers record those short Spanish language videos that are now in editing and post-production, as they say, for circulation soon. Just a small way, but I share that because I think it's so emblematic of the way that the partnership of the Arlington Public Schools has been essential in all of these efforts. So thanks for the brief soapbox to shout out our amazing volunteers, teams, and partners in getting our full community vaccinated so that we can make Dr. Varghese heart happy when that horizontal thermometer finally reaches something close to herd immunity in Arlington County. Thanks so much.
Thank you, Ms. Crystal, and colleagues, for the conversation. Well said. I had a short list of 3 items and you ticked every one of them off. We did get an email with the Spanish language short videos while we were in this session, and that's important as we seek to vaccinate all of us. Mr. Karantonis, I saw you, I think, at some point over the last 2 days in your T-shirt, and I got the glory of doing a little budget that morning and didn't make it for as much, but did promote it on social media. Thank you, colleagues. Oh, there's the T-shirt. That's awesome. Thank you. And I think with that, we will be adjourned. Thank you to our public who joined us. That's our COVID work session.
Mr. Chair, I want also to thank specifically because yesterday I saw our fire department, EMS people, and our police department accompanying DHS employees who were vaccinating homeless people around in Arlington in minuscule pop-ups. Here in Courthouse, down in Roslyn, up in St. George's. So that was awesome. Absolutely great. Thank you so much for this.
Fantastic. With that, a little addendum. We are now, thank you, Mr. Karantonis, adjourned.